Welcome to the Teaching Value in Healthcare Learning Network. Join us to hear leaders in the field share practical and tangible advice about how to develop engaging curriculum and health systems innovation to train a new generation of healthcare providers from diverse specialties and professions skilled to deliver high-value care. With the national concerns about rising healthcare costs as well as overuse, underuse, and misuse of medical care, Cost of Care and the ABIM Foundation created the Learning Network as a space to share ideas, educational materials, and strategies in open forum. Our goal is to discuss ways of getting started, implement, and sustain feasible innovations in teaching value at your institutions. The Teaching Value in Healthcare Learning Network will have three major components. The first will be monthly webinars, which will be 30-minute sessions to hear on-the-ground and national leaders share successful innovations with a focus on how to adopt them to your institution. Sessions will be held on the third Thursday of every month. Discussion groups are online forums to facilitate getting advice on how to launch new innovations, and we hope to help each other troubleshoot any challenges that might arise. The third, Toolkits for Educators, is a space for stored materials needed for dissemination of curriculum, shared by educators from across the country and Canada. We already have a number of tools available for you now, and will continue to add more over time. You can find this link on the left side of the Learning Network website. I am Reshma Gupta, the Director of the Learning Network, and I will be moderating today's webinar. Today we will share an innovation in teaching value and discuss in-depth practical components of implementation, including how to obtain buy-in, resources needed, and advice for sustainability and feasibility. We are honored to have Dr. Robert Fogerty join us today. Dr. Fogerty is an assistant professor of medicine and academic hospitalist with the Yale Internal Medicine program. He won last year's Teaching Value and Choosing Wisely Challenge for his innovative eye care curriculum, which stands for Interactive Cost Awareness Report. The initial pilot program was published in Teaching and Learning Medicine in 2014, and the program has started to spread to other institutions. We would like to make this session an interactive discussion and ask participants to submit questions online. We look forward to hearing a great discussion. So Dr. Fogerty, I'll let you take it away.
Thank you, Reshma. That was a very kind introduction. So as a little bit of a background, our teaching and learning program here at Yale, as Reshma mentioned, is called the iCare, and it's the interactive cost awareness resident exercise. And the purpose of it was to try and integrate some cost awareness education into our internal medicine training programs without displacing any clinical education. We're faced with a problem, every medical educator knows this in residency, where we have fewer hours to teach our trainees more information. And you add into that the idea of cost awareness, and it can become a little bit of a tense environment, because I think everyone would agree that your clinical training is really the most important aspect of residency. So when challenged with this, we did a needs assessment of our own program, and we realized that our cost awareness and our cost efficiency education was really not where we wanted it to be. So we looked around at pre-existing opportunities. We didn't want to add anything new to the curriculum, no more didactics, no more electives, and we really wanted to use minimal resources. So we identified Morning Report, which, as everybody probably knows, is a very ubiquitous conference. Pretty much every teaching hospital in North America probably has some version of it. And we had already had a regularly scheduled morning report where it's a case of an unknown that's pulled from the literature. So what we did is we actually added cost into that, turned it into a little bit of a game, and it's been pretty successful. We're pretty pleased with the results so far. The way it actually works, and I'll walk you through it, is imagine you're on the wards and you're a resident here at Yale. So on any given day, we have 4 different morning reports ongoing. We have 2 at our large academic campus, we have 1 at our VA affiliate, and we have 1 at our community campus. We split the trainees based up on level. So on Monday, your third-year medicine clerks would go to morning report, and no one else goes. On Tuesday, your interns would go, and no one else goes. On Wednesday, your PGY 2 and 3 residents would go to report, and nobody else goes. Each of those sessions will be run by one of the chief residents, and they present an unknown case that they've prepared from the literature. Usually it's the New England Journal or the Cleveland Clinic Journal of Medicine. And for the first 10 or 15 minutes, they present the real basic information about the patient. So you'll get the chief complaint, you'll get the history of present illness, you'll get medical history, surgical history, medications, and you'll get a thorough but maybe not comprehensive physical exam, but you'll get a 10 to 12 point physical exam as they presented it in the literature. At that point, the chief resident turns the session over to the learners, and in the room, usually about 8 to 12 people, they'll sit there and they'll develop a diagnostic plan of what they want to do. We want to get a chest x-ray, we want to get a kidney biopsy, whatever it is. And historically what's happened is there's a back and forth. The group asks for a test. We want a chest x-ray, for example, and then the chief resident has that information from the published literature about what this patient's chest x-ray actually looked like. So, for example, chest x-ray showed a widened mediastinum or whatever it is. And in this back and forth, the learners eventually get to a diagnosis. They present their diagnosis. We think the patient has an aortic aneurysm, and they're told whether they're right or wrong. There's a short didactic that follows about aortic aneurysms, and the case ends. What we did in eye care is we took that model, but we added in actual hard numbers from Medicare for reimbursement for all of these tests. So the case itself runs the same way. The learner walks in, sits down, they get the case presentation, they work up their own diagnosis, and they give their diagnosis to the chief resident. But in addition to having the results of the test, they also have how much Medicare would reimburse the facility for that test. So a CBC is $55. A chemistry panel, a basic chemistry panel, I think is $77. A comprehensive medical panel, metabolic panel is $130. So at the end of the session, the group of learners not only learn whether or not they got the diagnosis right, but they also got a bill. So, congratulations, you diagnosed someone with necrotizing pneumonia, but it cost you $174,000 to do it. So you got the diagnosis right, but that maybe wasn't most efficient. And that's well and good, and I think that would have been a great place to stop. But if you remember way back in the beginning, I mentioned that we did this at 4 different sites, so we actually turned it into a competition. And each group competes not only against their own peer level, but against the other peer levels, because everyone does the same case. So over the course of a week, everyone is exposed to the same case. They work through it themselves. We tell them not to talk about it outside of the room, and they don't. They respect that because they're competitive and they want to win. They don't want to give an advantage to their intern, for example. And then at the end of the week, we tell everyone how much they all spent, and we declare a winner. And the winner is the group that got the diagnosis right, but then spent the least amount of money to do it. They don't really win anything. It's just a source of pride. And since the teams, the house officers and the students rotate from campus to campus, from team to team, there's no hostility about this, and it just kind of has a nice flow to it. And that was what got everyone interested, the concept that they're competing against their peers. And we knew we had something here when the residents started losing to the interns, because that really kind of drove them a little bonkers. And they became so fixated on winning this that we had to adopt some new rules because, to be totally honest, they were cheating a little bit and just guessing. So the reaction to that is we actually have a minimum set of diagnostic tests that you have to order to be eligible. So whether or not you order these, you're going to be charged for them, and you're going to get the results. The example, to take a little bit of a day trip, the example was a group diagnosed Stevens-Johnson's from mycoplasma pneumonia because they got I think it was a chest x-ray and a mycoplasma IgG, and they just guessed, and when it was positive, they gave the diagnosis. And to have the residents who are already working very hard and very stressed out and have so many things on their plate, to have them put the mental energy into trying to cheat to win means that they were emotionally invested in this. So we thought we had them hooked at that point. The other thing that we do that's interesting is, if you remember, we really wanted to not displace any of the clinical education. So in addition to the trainee sessions, at the end of the week, usually on a Friday, sometimes the following Monday or Tuesday, we bring the teaching attendings from the various services and some of our more senior, well-respected clinicians into the room, and they work through the same case that all the trainees worked through the week before or earlier in the same week. But this is not a closed-door session. At this session, all of the trainees come back, and they actually watch their attendings work through the same case that they worked through 2 or 3 days earlier. And that would have been wonderful, but we give the attendings a little bit of extra instruction. We encourage them to think out loud and actually talk about why they're ordering the test that they're ordering and why they're not ordering the test that they're not ordering. And this is an unbelievable session, and we learn from each other a great deal during that session, because it's a magical hour where you get to talk about one patient, and you have world experts and local experts and well-respected doctors in a room talking about it. And the trainees pack the room, they're standing in the back. And what I think has been most fascinating about that session is the amount of clinical reasoning education that takes place for the trainees. When you're standing on the wards or you're in clinic, you're always worried about the pager going off, or you're worried about getting to your next admission or ending rounds, trying to get your early morning discharges out. But this protected hour gives you a chance to really flush out all of that clinical decision making, and that's the focus of that session. And what is an added benefit of that is that the attendings always spend the least amount of money, almost uniformly. And we realized after watching these enough that it's not because they're consciously considering the cost of the test. They're considering the worth of the test. They're considering the value of the test. Part of that is it a really expensive test? Part of that is it expensive or painful to the patient? Does it carry a lot of risk and radiation? Is it invasive? These are the things that they're talking about, and that gives the trainees a nice bracket. They need to understand that the cost of the test is very important and needs to be considered, but can't be considered in a vacuum. So that when the trainees go back to the wards, they're now thinking about the cost of the test, but they were learning how to think about that in a larger clinical scenario. So the idea that a test is good because it's cheap is not the purpose of this. The idea that a test is bad because it's expensive is not the purpose of this. It's picking the right test for your patient and getting rid of the tests that don't do anything. And the trainees really show us that they're thinking that. Every so often they'll say something like, oh, we should just get an MRI of the total spine. And someone says, that's a really expensive test. I don't think we need to do that right now. It's not going to add anything to our decision making. And that's the beautiful marriage that we're looking for. They considered the test, and they considered all of the risks and benefits of the test, and that's what formulates their decision. It's not only about the cost, but I think the cost of the test is really a component, and they're learning how to marry that together, which is, as far as we're concerned, right, what we want them to do. As Dr. Gupta mentioned, we've expanded this to a few other sites. We're doing it at Jefferson in Philadelphia. We're doing it at Johns Hopkins Bayview down in Baltimore. And they've done a few of our cases that we've shared with them. And right now we're finishing up our Train the Trainer curriculum. So hopefully they'll be able to pick this up and run with it. And at least on one occasion, and then hopefully again with the next academic year, we're going to all do the same case and then compare across campuses. So that gamification, that hook we saw between residents in our own program and interns in our own program, we think will only be amplified when we start to compare to our peer institutions. We think that the the competitive nature of our house staff is not unique to Yale. Doctors tend to be a competitive bunch, so giving them a little bit of anonymous and friendly competition, I think, will only help to pursue the curriculum. So I will.
Thanks so much for sharing that description, and I think it really made it clear. I think the curriculum is very clear, and it sounds like the residents and the students responded really well to the format, and it sounds like the role modeling that they saw with the faculty on Fridays made a huge difference. I just wanted to ask you more about what the faculty response has been from the ICARE curriculum at Yale.
So the faculty response was very engaged and optimistic from the first get-go, and sometimes little stories on the side can be detracting, but I love this one so much that I'm just going to ask everyone to bear with me. We were doing our first session, and the chief resident stood up at the front of the room, and I was in the room, and we were kicking this off, and the chief gave the description of what's about to happen. And one of our most senior, most well-respected clinicians, he's still active clinically. He's still the person we call when we absolutely have no idea what's going on. He was in the room, and he actually started to rub his hands like this, and then said, "This is wonderful. I've been waiting for this my entire career." And he joined the faculty 50 years ago. So to get buy-in from someone like that without ever participating in, just hearing what was described was very promising. Then at the end of the session, one of the former residency directors was in the room, the associate chief of medicine was in the room, our 50-year faculty member was in the room, and they were giddy and laughing and arguing about what this should be called. They called it a parsimony case, they called it a razor case, they called it the precision case, and to see that kind of exuberance and glee at the end of the session was not really, of course I was hoping for that. I wasn't necessarily expecting it. And they've continued that, and attendance remains very high. 2 years ago, for logistical reasons, we had to move morning report, which we typically do at 9:30. We had to move it to 7:30 for a year. And all of these attendings reworked their schedules to continue to attend, and they showed up at 7:30 in the morning and changed their childcare and the whole thing. So it's been from the get-go extremely popular with the faculty.
One thing that you brought up, which I think is really interesting, is kind of alluding to the culture change that seemed to happen through the ICARE curriculum, and I think it might help listeners get an idea of what existing curriculum you had in value before ICARE was implemented, and also what the culture was like at your institution prior to implementation, and then how you saw that change.
So our culture pre and post and other curriculum. So we started this, I finished my residence here in 2011, and then this was one of the first projects that I got going after I finished, and I think we did our first case that winter. And I can tell you that when I was in training here, immediately prior to this, our cost and value education was minimal. The hospital does have a they call it cost and value positioning initiative, but it didn't really make it all the way down to the house staff as a formal education initiative. And that was one of the reasons where we identified it as a potential avenue for improvement. So we didn't have a whole lot, and I think that was very frustrating for us because some of our faculty here have done unbelievable work on understanding efficiency in care. We've had syncope papers come out of here about which test is most cost effective. We had a fantastic paper about pacemakers come out of this institution, about the cost effectiveness of pacemakers. But when it got to the practical nuts and bolts clinical education for the house staff, there really wasn't a whole lot. And I'm going to be very clear here, I don't get credit for this, but around the same time that we were doing this, there was a larger push to bring this into the training program. So I kind of, I'm not a surfer, but I kind of caught the wave at the right time. So since then, other things that we've developed, we now on our computerized provider ordering entry, so our EMR Epic, when you order either a lab test or a radiological study, you actually get the Medicare reimbursement number for that test on the ordering screen. And one of our clinical scholars is doing a giant data set on looking at years worth of order entry before and after that. Also around that, we've done some attitude surveys around what cost means to providers. We just finished a graduating senior, we just finished an attitude survey of graduating seniors in multiple specialties, seeing how they think about cost and value. And we have just about a year ago started a quality improvement interest group with the house staff, and that's been very resident driven. We have a chief resident, a future chief, and a current other PGY3 who are leading that right now, and they are really looking into this. And it's very self-directed. They pick their own topics. One of the things that they're interested in is understanding the bigger picture of healthcare finance, which is obviously a huge pot to boil. But I think part of that is understanding how physicians interact with their ordering patterns and understanding how cost may or may not impact with that. So our culture has really changed a lot in the past 3 or 4 years, and I don't think that that's all because of this exercise, but the timing is certainly right, which is great. And the residents are very receptive, and they're asking for more of this pretty regularly, I would say.
I mean, it sounds like that as times are changing and talking about value becomes more common, you know, as you said, kind of jumping on that wave, but at the same time, it sounds like what you've been able to do is merge these silos of the health system as well as education to make it real for the learner. And I wanted to get an idea of taking started the curriculum, and what were the main things that you felt like helped you to get buy-in from the institution or from the education side, and the key things that led to it being a success?
So I think one of the key buy-ins is that we didn't ask for anything. Resident report already happens. The chiefs are already used to preparing cases. The amount of extra work for them was minimal. And they actually, the first year of chiefs, Jason Hevner, who is one of the co-authors on the teaching and learning paper, wanted to do this. So he was a stakeholder who had an initiative and was willing to work in the beginning. The fact that it added a new dimension to morning report, I think, brought some of the residency leadership on board. Morning report, we've all sat through very good ones and some not so good ones, and I think some of the not so good ones are due to a lack of structure. So we provided them with another structured report format that still allows for that freedom to practice your decision making in a safe environment, which is really important in morning report. You can ask questions about diagnosis and management without risking a patient. So we preserved that, but at the same time we gave them a structure so that they had a mission for the session. Other key factors in buy-in is that it was familiar. The things that we added didn't change report so that it was a new experience, so the learners could walk in and instantly know what was expected of them. We weren't sure if that was an institutional thing, so one of the questions that we asked with our new partner sites was, at the end of your first session, how comfortable do you think the learners were from the get-go? And they seemed to figure it out pretty quickly. So the barrier to participation from the learner was very low, that we asked for no extra resources, and the key stakeholder was that chief resident that first year, who was interested in doing realistically about an extra 2 hours of work once a month. to prepare the case. They say it takes about 3 to 5 hours to prep each case, and then they tell us that a morning report without this usually takes them about 1 to 2 hours. So we're really adding an extra 2 to 3 hours of work once a month. And we have enough chief residents that we can spread that out. So each chief usually only does it once or twice a year at most. And as far as the learners, they loved the competitive aspect of it. So that was really what got them to buy into it.
Great, and I have a question that's coming from our audience as well, but I did want to just make an announcement to those that are listening that you can ask questions through the Q&A app if you click on the square at the top of the screen to open it. But this question builds off of what you were just saying, but instead of the things that led to success, it's thinking about the flip side of that. So what are the barriers or kind of challenges that came up along implementing, and what are the ways that you were able to troubleshoot them and overcome them?
So one of the biggest barriers right up front was getting reliable financial data. The first few cases we actually used our charge master because, believe it or not, that was a little bit easier because anyone who's gone on the Medicare website knows that it's all there, but you have to figure out where you're looking. As part of the EPIC initiative that I mentioned with using the Medicare fee in the Medicare reimbursement in real time at the time of order entry, that barrier has been reduced greatly. So really practically speaking, one of the biggest barriers was just figuring out a method to rapidly find these charges. We found that there are about maybe 50 to 100 tests and procedures that come up over and over again. So I downloaded the CMS laboratory fee schedule, and I downloaded a procedure fee schedule that is actually from the outpatient environment. And then that's what we use. And the idea in the educational initiative is not to necessarily get the dollars right, but just to give them a concept of what we're actually talking about. The EPIC data is much more reliable. They have a much more robust infrastructure for that. But just figuring out a mechanism to rapidly search the giant Medicare information was a big hurdle. Another hurdle was getting residents to report on time. We found that these sessions really take the whole hour. So we did a few things. We figured out a way to shave off some time so that you can really do it in about 30 to 45 minutes if you need to. Because it kind of unique to this relative to other reports is if you're 10 minutes late and you've missed the history of present illness, the chief complaint, and the physical exam, your goose is cooked. You're not going to be able to really participate in the session. So figuring out a way to give them that barrier, that buffer zone at the beginning was very important. And my sister uses the phrase a kiss and a slap. So the resident engagement and getting so involved in the case that they figured out a way to cheat was a little bit of a barrier at the same time because it kind of threw us back and we weren't really sure how to respond to that. So we loved seeing them engaged, but we had to tell them to cool their jets a little bit. And we learned a very important lesson there that we have to keep some degree of realism. So we gave them the minimum diagnostic workup at this point. But more importantly, it issued them a new challenge that we think they're going to try and circumvent us again. They're going to figure something else out. So that kind of living, breathing organism where they're going to try and beat us, we have to stay one step ahead of them is an ongoing challenge, but it's one that we welcome because it means they're still thinking about it, they're still engaged, and as one of the chief residents said, you know, bring it because we'll stay ahead of you, we'll figure it out. So those have been the big barriers. As far as infrastructure, we needed a conference room and a projector, which we already had, so there wasn't a lot of infrastructure problems there. And for hard support, we didn't really need any because essentially it's a labor cost is getting someone to prepare the case And like I said, that was a minimal investment and it's just become part of the fabric of the residency now, so I don't see them stopping to do that anytime soon.
Great. One other question I think has come from the audience as well is there's anything you wish you had known ahead of time before starting the curriculum, or any advice that you would provide someone else embarking on implementing eye care at their institution?
So hindsight, boy, yeah. So I wish I had known how, and I should have known this, and I realize I just said that, but I really should have known this. When we first started out with the charge master data, there was no heat, no one got angry, no one no one called me and said, stop doing this, but the numbers are so sensationalistic that I think we lost a little bit of buy-in. And I don't want to get too much into this, but everybody knows that if you don't have insurance, you get the unadjusted bill, and then there's the negotiation, and that's, I think, a topic for another day. But imagine yourself, you're a PGY2, you've been a new resident for 2 years, and all of a sudden the workup that you just directed with your fellow residents just resulted in a $74,000 bill. There's such shock, and the first response is, well, that can't be right. And I think that was a little bit of a hiccup, that we learned our lesson. So we needed to structure this a little better so that there is still a little bit of sticker shock, but it's a manageable amount of sticker shock, so that they stayed engaged and they had faith in the numbers we were giving them. So moving over to the Medicare numbers, not only are they a little bit more easily available, they're a little more realistic because such a large number of our patients are on Medicare. The trainees have heard of Medicare, and they don't get lost in the quagmire of the natural question that follows when you get a charge master, which is, well, is that what someone actually pays? And then your session quickly gets derailed into, well, it depends what their insurance is, and are they capitated, and are they in an HMO, and all sorts of problems like that. So the best way to avoid that was to just go ahead with the Medicare data right up front. So I wish we had done that in the beginning. The other thing that I think I wish we had done is identified PGY3 residents to do this rather than the chief residents. Our PGY3 residents have a teaching assignment. They have to give so many reports over the course of the year. And I think this would have been a great way to introduce them in a self-study environment to these kind of costs. So those are the two major learning points. The smaller one is I wish I had developed a better catalog in the beginning, because some of these cases are so profound that I wish I still had the files, but the chiefs graduated, and the flash drive got lost. So I wish we had actually had a better archive system right from the beginning.
Great. We just got another question from one of our audience members that I wanted to share. Part of the question is talking about implementation and the culture change that you might have seen, and we discussed that a little bit. But this is from a second-year resident at Boston Medical Center who is asking, did you actually see a decrease in excessive testing in practice? Is it something that you were able to measure, or are you studying that?
So the question is, it's a great question from a PGY2 at Boston Medical Center, which is, do we think that this teaching session has really changed house staff culture as it regards to ordering, and do we think we'll see a decrease in excessive testing? This is a fantastic question. I don't know. There are so many avenues that tests get ordered, and there are so many providers that touch a patient, and learning or just gathering all that data is well beyond my capabilities. What we have seen, I think, is organic discussions in charting rooms about cost issues, and we didn't really have that when I was a resident. So I'm not going to take credit for culture change, but I think that what we have done is already, I think what we have done is given the residents just a little bit of a toolkit so that they can have these discussions with themselves. And every so often on rounds, so I'm a hospitalist, that I only practice on the inpatient service, and a big chunk of my time is on our teaching service. And every so often, a resident or an intern or even a medical student, which is really fantastic, will actually ask on rounds, that's really expensive. Do we need to do that? Or does anyone know how much that is? And it extends to therapeutics, it extends to procedures. So I think we may have, I don't think the boulder has fallen off the other side of the mountain, but I think we've at least gotten it to the top of the hill, and it might be going over sometime soon, I hope. But as far as hard data, we have a giant data set. Last I heard there were 8 million data entry points in it that's looking at all provider ordering in Epic after our go live with the real-time cost display, the real-time charge or reimbursement display. I think that data set is still a few years out from being analyzed, but I hope we see a change, and I don't know how much that will be to us, but I think in the educational environment, the discussions that we hear anecdotally in the charting room are definitely changing since we've started doing this. How much of that is due to eye care, I don't know.
And one question from one of our viewers in Chicago has asked how long it takes chief residents to prepare these eye care cases.
The chief residents have told us that from start to finish, it takes them about 3 to 5 hours to prepare the entire case, and that includes going to the literature, finding the paper, reading the paper, a variable amount of background information on the conditions that are being discussed in the paper, and then preparing the slide set and sharing it. And they tell us that when they were doing this type of a case before, it would take them about 1 to 2 hours. The extra preparation time is the slide deck is a little bit more complicated. It uses one of those Jeopardy templates where you can click on a number and it brings you directly to the slide, and then you can click back. So that takes a little bit of extra time. Getting the cost information from our pseudo database takes a little bit of extra time, but they actually find themselves learning more about the disease process and the tests as well, because they find that the questions from the learners are maybe a little bit more pointed than they were before. Unfortunately, the current year of chiefs basically have only known it this way, so it's hard for them to compare it to what we were doing previously. So they compare it to our other morning reports. But historically, when the chiefs that grew up, I guess you could say, in the old reports, and then we started doing this, they noticed the questions are just a little bit more pointed before the teams actually ask for the test. And on the back end, there's a little bit of extra work after the case to collate all of the responses and all of the bills from all the different groups, and that probably takes them a couple of emails and then an Excel spreadsheet preparation. But all in all, it's about 3 to 5 hours from start to finish, which is about 2 hours more than the standard report they were doing.
Thank you, Rob, for joining us today, and for all of you joining for a great discussion. Remember to check out the Tools for Educators link off the main page of our website on the left side, where you can look at Dr. Fogerty's slide decks, as he mentioned, and other materials needed to adapt these sessions to your institutions.